Welcome to the robotic-assisted Whipple procedure performed at Capital Health in Pennington, New Jersey. This first part of the operation consists in mobilizing the right flexure of the colon. This maneuver is done quite extensively, and we use sharp dissection as well as cautery to achieve it. We are now starting the Cocker maneuver, which is done similarly with cautery and sharp dissection. The duodenum now is reflected medially. As you can see, the kidney appears in the background, and we are now starting the division of the gastrocolic ligament. This maneuver is completed primarily with energy. We're now moving towards the gastro-duodenal junction. Part of the gland appears in the screen. The objective of this part of the operation is to identify the gastroepiploic vessels and the gastrocolic trunk. Some of the small attachments of the posterior part of the stomach are divided, and now the gland appear more evident in the screen. This is the gastroepiploic artery. It would be double clipped and divided. Similarly, the gastroepiploic vein will be double clipped and divided. Now going around the gastroduodenal junction, and with the help of the umbilical tape, we're going to fire staples distally to the pylorus. This phase shows the dissection of the gastroduodenal artery and the division of it between clips. We're now extending the dissection of the hepatic hilum. Portal vein is evident in the background. We are now developing the channel between the superior mesenteric vein, the portal vein, and the gland. And now we are dividing the head of the pancreas from the body. This maneuver is obtained with cautery and is done very carefully. The division of the gland is completed, and now we are dissecting the portal vein and the superior mesenteric vein from the head of the pancreas. We like to divide the intestine with a mechanical stapler from the right side of the patient. Using a vessel sealer, the small bowel mesentery is divided, and now we are completing the division of the spacement from the SMV and the portal vein and the superior mesenteric artery. This maneuver is done primarily with cautery and sharp dissection. This is the division of the common bile duct done just proximally to the insertion of the cystic duct and the spacement has now been completely resected. This shows the pancreatico-jejunostomy. The prolin stitches have been passed through the gland and the intestine. The intestine now is open in the antimesenteric border, and the ductal mucosal anastomosis will be obtained with 5 OPDS with running suture. We've left a stent across the anastomosis. This helps the anastomosis and prevents leaks. Now moving towards the choledochojejunostomy, which is done using a 5 OPDS with a running technique. We don't stent these anastomosis. And we're now getting ready to perform the last anastomosis between the stump of the duodenum and the jejunum. This is done in 2 layers, exactly in the same way that we would do it open. This is the end result.